before we get started, everybody, I'm going to just take 1 second to thank ThroatScope. Because of ThroatScope, we have Dr. Baxter here with us today, and he is in high demand. If you're not familiar with ThroatScope, you know, it's the light up tongue depressor that I often use in my practice. And we'll probably be showing you, yeah, you go it too. Yeah. We'll probably be showing you a few tips and tricks with this throughout the evening. But first of all, I want to go ahead and start by introducing my friend, Dr. Richard Baxter. So I'm so used to calling you Richard, but I'm going to be professional and call you Dr. Baxter. Dr. Baxter, tell us a little bit about yourself and how you came to, on this journey to really help children who have tethered oral tissues.
Sure. So I grew up in Dallas, Texas originally, and ended up at UAB for dental school. And then we moved to Ohio for residency, for pediatric residency. And while we were there finishing residency, we had our girls, which are here in the running around here, but they're now, Noelle and Hannah. And when they were born, the lactation consultant told me they had a tongue tie. And I thought, I mean, sure, I've been through dental school, been through pediatric dentistry residency, like I should know what a tongue tie is, but I had no clue. And I was, I guess, open-minded enough to look into it more and say, okay, let's look at this. The pediatrician said, oh, I don't see much, but if your lactation consultant wants me to, I'll clip it anyway, which was not the best advice, but we were sleep deprived. So we said, okay. And she clipped it and it didn't make a difference. We thought, okay, that wasn't the problem. And then fast forward another couple of weeks to us figure out, wait, what's going on? She said, no, it's still tight. You should see this dentist who has to do a lot of these with the laser to get it done right. So anyway, we go see this dentist about an hour and a half away in Dayton, Ohio, and he's with the laser, and then it helps a lot. So then we moved down to Alabama about a week later and started the practice. And then a few months later, we had people asking about tongue ties, lip ties, and I started looking into this and did lots of research and courses and everything I could. And yes, it's been a journey. That was about 5 years ago. So
it's been a real personal journey.
Yes, and then I realized I had a tongue tie too for 30 years that I didn't know about. And then our latest edition, Molly, who's 7 months old, as soon as she came out, first cry, what I was like to the tip tongue tie. So
really,
yes.
So is that common? Does it often run in families?
Often, not always, but often it does. So often parents won't realize they had a tongue tie until we do the kids, and then they're like, "Oh my gosh, can you check mine?" And dad's not always, but we blame everything on dad anyway for stuff. But yeah, and here's the girls. Yeah, they're
hi, sweetie.
Yeah.
So I'm excited because we have some real life children that you're going to be showing how to do an exam. But can you explain to everyone listening how you would typically do an exam in your office?
Yes. So normally we do an exam in the dental chair or like a knee-to-knee board, and we lay them back. That's the best way. You come from behind and use 2 index fingers, and it's like a mirror, and then pull back like that. We use magnification. So I have magnification loops, and I have a little headlight here so I can see everything, my props there, so we can see what's going on in high definition. So that really helps a lot. So,
but you know, just to be HIPAA compliant and be careful of patient privacy, we're going to use your little girls tonight, and we're going to have them we're going to have them face the camera. So, gosh, who's ready? Who's ready to be a TV star?
Okay. Okay. All right. No, I'll go first. It's okay. We'll go right now. Here, Hannah, you can come stay right here. Sit right next to her. It's next to Sissy. So we'll see. All right. Okay. So scoot up a little bit, Noelle. Scoot up. So here's how the key is really feeling it. All right. So open real big. Now we've already had theirs done a couple of times.
Okay.
So lift up. So Noelle, she doesn't even have a frenum because it's been lasered a couple of times. As a baby, you know, then we redid it at age 4 with the CO2 laser. Lift your tongue up, baby. So the key is elevation. So can you stick your tongue out? So stick your tongue all the way down your chin. How far can you stick it? So a normal tongue should come at least halfway down the chin. A lot of times people say, oh, it just like, you know, goes over the lips. Pull back a little bit. So if it just comes out to here, that's not far enough. Yeah. Like, oh, that's good. It really should come about halfway or 3/4 down the chin. Stick all the way down. Good. That's perfect. I mean, all the way. That's perfect. And then can you lift up real big, Noelle? Real high. Good listening. Okay. And so right here, you can feel. So another key is feeling it. So if some gloves on. If you're a speech therapist, you know, y'all have gloves too. but just feel under there, and then lift with 2 fingers like this and pull back, and you can feel the tension on it. You can't really see it because the lighting, and if you try it with the throat scope, it doesn't even work too. The camera lighting is not great, but can I see? Lift it.
Oh, that looks good. That's helpful.
Maybe. Yeah, right there. So you got to pull back with 2 fingers. You can see it pop up. Okay, Hannah's turn. Okay, here. Thank you, Noelle. That was really helpful.
Thank you, Noelle.
Okay, here you go, Hannah. And if you look in the dedication page, I'm not sure what page it is, like page 5 maybe, it says dedicate to Hannah and Noelle. There it is. Right there.
Oh.
All right, these are them in case you're curious who these Hannah and Noelle are. Open real big. Lift your tongue up, baby. Hannah's is a little bit more of a string. Lift your tongue up all the way. Good. And then stick it out all the way. So normal tongue should elevate 3/4 to all the way to the palate, to 100% of the way. If it only lifts halfway or less, then I would definitely say that's restricted.
And do you mean the tongue tip should elevate, or what part of the tongue? Yeah,
the tip. You should be able to see the whole tip up to the top. Open real big, lift up all the way. Yeah, so hers goes about 75% of the way. Can you put it straight up, baby? Put it up, right up here to the spot. Open all the way. Perfect. And then stick your tongue out. You stick it all the way down? Yeah, see, it's going all the way down. Good, perfect. And then open real big, lift up. And then so another key is if your kid is 2 years old maybe, you might need a tooth chair. You can get these on Amazon or eBay. They're like $5 or $10 actually. You want to sterilize them, so you need a sterilizer. But we use these in the office if a kid's 2 years old, might bite me. So she's not going to bite me, but open real big, and then it pops like popcorn. You just got to be careful it doesn't hit on the lip. Just keep it on the teeth there. Perfect. And now you can lift up your tongue. Or you can get under there. You can see it better. So if it's a kid, you worry about getting bit. And I think that's why a lot of kids, perfect. Thank you, Hannah. And that's why a lot of kids don't get checked, is because the pediatrician's like, I'm going to get bit if I try to get in there. So anyway, I think that is key. But.
And so we've been talking about about ankylglossia, about the tongue tie, the frenum that's holding down the tongue itself, and where it inserts and how tight it is, et cetera, et cetera.
Yeah.
But just as a side note, we're also concerned about upper lip ties and maybe even buccal ties. Can you just speak to the audience a little bit about that?
So labial sounds, so BPNM, so they can help spoon feeding. If you're not able to get the food off a spoon, you'd be able to speak to that better. And then buccal ties are up in the cheeks. So mainly it's the upper buccal ties. You do have lower buccal ties, and there's a lower lip tie too. We don't see those impact as much. Buccal ties, there's no research on it. It's really like, how would you parse out that data? Like, was it the lip tie, the tongue tie, or the buccal tie if you did all 3 at the same time? I don't think we're going to see much, if any, data on buccal ties, just because it would be so hard to separate that out. We just did a prospective study at our office. We looked at lip and tongue tie versus just doing the tongue tie. There was no difference in that study with 30 kids.
Wow.
We measured speech, feeding, and sleep on them too. I have the data I can pull up to you. But I'm excited. We'll get that published next year. So awesome. It should help, because it'll be the first study linking feeding and tongue ties, other than our case series we published last year. So that. We need to get on it. The research, it's right. We're ready. So anyway.
Well, it's good that you're bringing that up, because I'll post it in the comments here for everyone. But I wrote a blog about a year ago about tethered oral tissues, why I can't wait for the research.
Yes.
You need the research, but a lot of this really is common sense. And if I can tell that child's restriction is impacting feeding function, especially for me, because I focus on feeding.
Sure. It's huge.
Then naturally, I'm going to reach out to an expert like yourself and get your opinion in terms of how severe the restriction is. Can you speak to a little bit to, this is so fun to have your girls here. They cannot go to bed. They have to stay here.
Okay. Think about the researcher.
Can you speak a little bit to just the issue around, you'll see these pictures posted on social media all the time. Is this a tie? You can't really tell from a picture.
No.
It's an extreme restriction, correct?
Yeah, it really matters more like the function and the symptoms the child's having. Sit down, girls, I can't see. It's okay, y'all are cute anyway. But the appearance is not nearly as important as the function. And so we have some kids where it looks like it's pretty tight, like, they can lift less than halfway but have no symptoms. So then I'll just counsel parents, hey, if it becomes an issue later on with speech or feeding or sleep, then let us know. But if not, then just, let it be for now. If it was my girls, I would definitely do it because I see the effects, but some people just aren't there yet. So we never ask anyone to do it. We really want to make sure that they have all the knowledge, though, because, like, again, mine was tied for 30 years. No one ever told my mom, and my mom was a physician. I've seen countless dentists, oral surgeons, orthodontists, and no one ever told me. So it can make a huge difference in a child's life. And I had to have jaw surgery. I had to have an expander. It affects dental growth and development. I was in speech for several years. I still have trouble with my L's sometimes. So, anyway. It can make a big difference. But again, it's more really to say if it's a tie or not. You can't diagnose over social media, or when people email us, I say, yeah, that looks suspicious, but really, you need to come in, we need to feel it. This is about the tension.
And so when you're feeling, we're specifically talking about a tongue tie now, when you're in there feeling, can you describe just the different elements that you're feeling for?
That's a good question. Yeah. So basically, I'm just running my finger underneath. It's called the Murphy maneuver after Jim Murphy in San Diego. He's a pediatrician. Or like Larry Kotler calls it, a guitar string. Feels like a speed bump. It just feels tighter than normal. But what's crazy is some kids looks like it's totally nothing there, and then you pull back on it and it pops up. You can see what it is. It's a webbing of fascia. So it's a thick webbing, and it looks like this. It's spider web, and it's pulled up like that. And so that's what you're really seeing. And when you did it with scissors, you couldn't even see that. Hold on, girls. I gotta. You just want to be in the camera frame. But it is the thick webbing of fascia, and so it pulls up like this. And so when you release it, it just falls away and just disappears. But if you do it with scissors, you can't see that. With the laser, you can see it because you're just removing it all. It's real easy.
And tell me if this is correct, but when I've held babies for the providers who do the releases here in Colorado, and they see that fascia appear, the way they often tackle it is that they're very, very careful with the laser, and they might do a little bit of that triangle like this, of a diamond, I should say, not a triangle, but then they'll actually look at the fibers, and sometimes they'll do a little bit on one side and a little bit on the other to make sure that we get a nice even balance for the tongue. Is that the correct way of talking about it? Is that the way you would?
No, for sure. Yeah, you want to get the fascia. It's like it's a diamond shape. It's a triangular prism. So when you make a horizontal cut through a triangular prism, you get a diamond shape.
Oh,
and
sure.
That's what the freedom's kind of like this, and so it's a 3D structure. Thank you, Noah. She's plugging things back in. But basically, it can make a huge difference the way it's done. So if they only cut halfway, it's like if I have syndactyly, your fingers are stuck together. You cut halfway, like, okay, I don't have much better function now. Like I playing baseball or piano, like I'm still gonna be in trouble if I syndactyly. You really want to cut it all the way, and so you can have full function. And so a lot of these kids break, oh, they've been clipped before, and there's no difference, or there's a tongue tie clipping doesn't make a difference, or like the Cochrane reviews. The research is muddy because some studies they may do it perfectly or really well, really a good release. Other studies they didn't get it; they only got halfway. And so if you only take one tonsil out, it's not going to work. If you take half an appendix out, it's not going to work. So it makes sense to me. You have to remove all the restriction, and the best way to tell is if it's a diamond shape afterward, because now we know it lifts all the way up. It's like the tongue. I give an example, and so you see the diamond shape right there. It can make a huge difference for a lot of kids, and
and jumping back to our lip ties for a second, can you just walk everyone through? I know one thing that I always teach in my courses is that when you do flip the lip, you try to make sure that the top lip covers the nostrils, especially in a baby. So it's literally, and I fret up there.
I don't even have, I had jaw surgery, so I have like all the way up. Huge vestibule there. There, and they cut my jaw and moved it forward.
Wow.
But all that to say, so the lip tie, really, the main thing we're doing lip ties for is for dental reasons. So like every time they lift the lip up, the kid's like, they're trying to brush the kid's teeth. And it's a big gap in there. So that really makes a difference. For babies, obviously, nursing babies, we do that all the time. I'd probably say 90% of the babies we do lip on. For the girls, we did Noelle's lip and tongue as a baby, and then she nursed great. Hannah, we were trying to be conservative. The dentist said, her lips, not that tight. Here's Hannah. It's like not that bad. So we just did her tongue. plus like, we didn't have no money. We were residents. I was a resident at the time. And so we did just her tongue. And then she really struggled and had reflux and all these issues. And then at a year old, she had a big gap in her teeth. So ended up doing it at a year old. I was like, oh, I wish we'd done it as a baby. So we had our own little mini twin study there. And, you know, I don't know, it's an N of 2, so it's not huge power, but Noelle could nurse great afterward. And Hannah still really struggled because her lip could not flip out as well.
Yeah, for everybody listening, the top lip, when it comes to breastfeeding specifically, needs to flange up, so that if this is the breast and this is the mouth, it needs to flange high enough that the breast not only gets behind the lips, but actually goes all the way back into the throat.
Hard, soft
the back of the throat is where we have receptors to help the baby learn to latch, as well as in the lips. So watch, everybody. If this is the breast and this is the lips, and if the breast will only go in this far because the lips can't flange high enough, what happens? They hit these receptors, and the baby clamps down too early, and mommy ends up really sore, and baby frustrated and fatigued. So that ability to really lift up that lip is important, but it's also really important in terms of the ability to clean off a spoon, to clean off fingers, to get that good lip closure. And when you have kind of a tight, tethered upper lip, what works really hard is the jaw and the lower lip. And it's just very inefficient, and we end up compensating. So I think that's where the marriage of your expertise and a speech pathologist or another professional who's really trained in tethered oral tissues comes in, because when it comes to feeding, what we're looking for is function, but we're also looking at, are they overcompensating, and is that going to cause fatigue or jaw pain or speech issues? We don't have enough research to know A, B, and C, how it all falls into place. We have to use our clinical experience and put all the puzzle pieces together as a team.
Yeah, there was a study done, Walls 2014, where they took babies and they looked at one group that was clipped as a baby. And again, I don't know how well released they were. They were clip and snip are a 4-letter word to me. So it's fine. Like, oh, the baby's fine. Like, we're just gassy and fussy and not like, yeah, he's on a bottle and like, it's just like all these things. Like, no, those are compensations. But anyway, so they took one group and they had a tongue tie release. Kids at 3 years old with their tongue tie released had the same speech as the ones who never had a tongue tie. And the ones that weren't released had more issues. So yeah, Walls 2014, parental perception of speech, I think is what it was.
Wow. And I understand that you have a few slides to show us. One in particular I'm interested in sharing with everyone so they can see what an exam looks like in the professional dental chair, the office, the way you would typically do it.
Sure, sure. Are you able to pull up the screen there?
Yes, I sure will. Here we go.
Awesome. Lots of good questions coming in. We'll definitely get to those later.
Hang on one second.
Okay, good.
This is so fun. Hang on one second. I'll get it the perfect. Okay, I'm going to have you disappear for just a second. And I think everyone can still hear you. There we go. Yes. Uh-huh. Wow. I think you bring up a really good point. And I want to also say that I've seen the opposite, where I end up seeing a child who's 6 years old, severe feeding delay. I'm thinking of one particular child who had autism. And when I literally could see the tie from across the room. I mean, it was one of the most severe ties I've ever seen. And I asked the mom about it before I even examined the child. And she said, well, he talks fine, so nobody ever thought it was impacting feeding, except the way he talked was through echolalia, where you're repeating, repeating, repeating.
They said they couldn't hear me. I was seeing there.
Oh, okay.
There was like 15 slides saying no sound, no sound. Okay, so I'll say it again. Basically, what we're doing is we want to check from behind. We were talking about speech, and the little girl was from South Carolina, and it looked like there was nothing there. And mom said, please just try anyway. And so we, again, there's like a posterior tongue tie. Like you couldn't see much, but all the symptoms of a tie. She probably had like 30, 40 check marks on the form: speech issues, feeding issues, and sleep issues. So we did it, and within a week later, she was talking better, and she was sleeping better, but not eating better. So then about a month later, month and a half later, she was eating better, sleeping better, and talking better. And so it made a big difference putting 2-word sentences together. And mom said the biggest difference is she's more cuddly. Like she is less tense in her neck, which like we hear that from adults a lot. You don't think about that for 2-year-olds, 3-year-olds. So anyway, I wish I could hear the other stuff. But basically, yeah.
No, that's great. And I'm just going to
techniques.
No, it's okay. And I'm just going to take a couple more minutes just to kind of reverse that thought, just to round out our conversation.
Sure.
And then we'll take some questions as well.
Sure.
I was just mentioning that we just talked about one of your case studies where she started talking better. Mm-hmm. But I can often see the opposite, and mm-hmm. it's more because of a lack of knowledge. So one example mm-hmm. is I had a 6-year-old who only ate purees. That was it. And he had autism. He had never had feeding therapy. He had speech therapy. Mm-hmm. But when I literally could see the tie from across the room, it was one of the worst ties I've ever seen. Now, is it impacting function? I don't know yet, but I could see it. And so obviously an anterior tie, quite restricted. And when I asked his mom about it, she said, well, he's been in speech therapy his whole life, but his articulation is really clear. So they mm-hmm. never thought it was impacting him. Well, the reason why his articulation is so clear, in my professional opinion, is because he's echolalic. He doesn't have a lot of fluid speech. He has a lot of repetitive speech. Mm-hmm. And if you've ever watched America's Got Talent, twice we've had ventriloquists win, and mm-hmm. they can keep everything very still and still be quite precise in the way they talk. You know why? Mm-hmm. Because they practice the same sentences over and over. And that's what this young boy had done. Mm-hmm. He could say the same things over and over with barely moving his mouth. He was an excellent ventriloquist. Yeah. So in my opinion, I suspect it probably was impacting language. Yeah. So his articulation or speech was beautiful, but he wasn't able to express more language because he had to rehearse. He couldn't rehearse it over and over and over because language is spontaneous and variable.
Mhm.
And he had his immediately laser released here at Children's Hospital. And this always makes me tear up a little bit. He tried a new food the very first day of therapy. He
Yeah,
wanted to try new foods.
I
He was a
know.
little scared, but he wanted to. He just never had the function to
I
do.
know. We have so many autistic kids that have speech issues, feeding issues, and sleep issues. And they're like, oh, that's just the autism. It's like, well, maybe, but maybe not. Like, and what's crazy is we had some that like, there's like nothing there. I can pull a picture later. Apparently you can't hear me though if I pull pictures. But he had perfect function, got all the way up to the roof of his mouth. Mom said, please, if there's a 2% chance of it helping, please just do it. It's like, it's probably 50-50, but we'll give it a try. That night he slept deeper. Mom thought he was dead. He was sleeping so soundly and not snoring. He didn't make any noise. He was eating better. He stopped choking on things like that week. And then he started talking. He was nonverbal. He was 9 years old. That's happened a few times. We've had 9, 10-year-old boys that have been autistic, nonverbal, and it looked like there was nothing there. We released it anyway, and they started talking. That's not every time. We've had like a 14-year-old, we tried that and it didn't work. So, but
I think what you're really expressing here so well is that every kid is different.
oh yeah, for sure.
It's different. Every lip is different. And we really have to look at the whole child and respect the family's values as well. And most of all, it always comes down to function.